You're listening to Beyond Wellness Radio, bringing you the cutting edge in health, biohacking, and sports performance. Stay up to date and listen anywhere and anytime on your computer, tablet, or smartphone by subscribing on iTunes. Catch your host, Dr. Justin Marchegiani, as he answers your burning health questions as well as interviews from world-renowned guest experts. For more Beyond Wellness Radio, go to beyondwellnessradio.com.
Hey there, it's Dr. Justin Marchegiani. Welcome to Beyond Wellness Radio. Feel free and head over to beyondwellnessradio.com where you can access our full podcast transcriptions. While you're there, you can also sign up for our thyroid and female hormone video series. This series goes into the root cause of why your hormones are out of balance. While you're there, you can also schedule a functional medicine consult with Dr. Justin, myself, where we'll dig deeper into the root cause of your health challenges. Feel free and think of sharing this podcast with at least one person. This podcast grows by people sharing it. Sharing is caring. If you can think of one person that can benefit from this information, please feel free and share it. If you're enjoying the podcast, make sure you subscribe on iTunes. You can also click below the video or podcast where you'll see the iTunes review button and leave us a review. You can also sign up for the newsletter at beyondwellnessradio.com where you'll get updates before anyone else. Thank you so much and enjoy the show. Hey there, it's Dr. Justin Marchegiani. Welcome back to the show. Today I have an awesome guest, a friend and mentor, Dr. Peter Osborne. Peter's got a book out right now called No Grain, No Pain, all about reducing chronic pain by making simple dietary changes. And I first heard of Peter about 5 or 6 years ago because I was on one of these conventional gluten-free diets and I wasn't quite having the results I was looking for. I still had some skin issues, some rosacea, some inflammation. And he was the first person that put the concept out there that really resonated with me called being true gluten-free and the phenomenon of gluten-free whiplash. So it stuck with me 5 or 6 years ago, and Peter's out there helping thousands of people. He's reaching out to hundreds of thousands of people via his weekly emails and this new great book that we want to talk about and get some more information out to all the listeners today. So Peter, welcome to the podcast.
Hey, Justin. Thanks for having me. It's great to be here.
It's great for you to be here. Before we start, what did you have for breakfast this morning?
Right out of the gates, huh? Well, I had a couple of scrambled eggs in coconut oil with a cabbage salad. I had some purple and green cabbage with some shredded carrots on top, some pecans, and some sliced red bell peppers. That was breakfast for me this morning.
That's great. I was hoping you weren't going to say a gluten-free bagel.
No, I stay away from anything gluten-free. At least labeled gluten-free, right?
Yeah, absolutely. Now, one of the podcasts I first heard of you on a few years back, you kind of talked about the history of gluten. I think it was Dr. William Dickey. He was a physician over in Holland, and how he came about connecting the dots, I think, with World War II rationings that grains, especially wheat, barley, and rye. And as you put out there in your research, it's much deeper than that. But can you just go over just a brief overview of the history of gluten and how we know it to be, what it is today from a clinical perspective? Cutting it out actually helps with a lot of these issues.
Yeah, this is a really unique story. So, the physician was treating kids in a pediatric ward during World War II. And what happened was grain was rationed, and so no grain was available as a food source for the hospital. So the kids all went into spontaneous remission. Now, this was at a time in our history where we knew of celiac disease. We just didn't know what caused it. So here all of a sudden, grain's no longer available. All these kids are healing because celiac disease is basically, it's a disease, in pediatrics, it's a disease where you vomit and diarrhea until you dehydrate and die. So he wrote a paper. It was published in 1952, and the same year, a group of researchers at the University of Alabama, Birmingham, did a study on 10 patients with celiac disease. Now, here's the sad part. This study was done on 10 patients. This is the study that isolated the protein that we commonly refer to as gluten. This protein is named alpha-gliadin. And they said, look no further. We've discovered the cause of celiac disease. It's alpha-gliadin. Therefore, all these other things are fine. All we really need to worry about is anything that contains alpha-gliadin. And this is where wheat, barley, rye comes from. is when we're referring to gluten in the FDA and the definition in the grocery store is referring only to alpha gliadin. It's not referring to this family of proteins, which gluten is technically it's a family of proteins found within all grains, meaning corn, meaning rice and sorghum and millet. So not just wheat, barley, and rye. But again, this study isolated alpha gliadin, and it was again only on 10 patients. But this was kind of the platform moving forward. And another group of physicians did a study and wrote a book on it. It's called, if you've heard or read, it's one of these books. I'm actually pulling it off my library shelf right now by Sidney Valentine Haas. It's called The Management of Celiac Disease. And they did this study on 600 patients. So again, a comparative, 10 patients versus 600 patients. And what they found is they found that really grain-free was actually what led to a remission. And they had a remission in 600 patients. I mean, so 100% remission rate versus today, if you look at the standard gluten-free diet, what is the remission rate if we measure the components of celiac disease, which are antibodies, persistent inflammation, as well as villus atrophy on biopsy? If we look at how many of the patients with celiac disease actually are cured with a wheat, barley, rye-free diet, it's in essence, it's less than 9%. So it's about 8% that actually experience a curative rate. So this was my first kind of techie endeavor into, or scientific endeavor into this, because for me I was eating all these gluten products just like you, gluten-free products. I was drinking the gluten-free beers, I was eating the gluten-free breads, and for me what was happening was I felt worse. I could go eat a loaf of wheat bread and feel better than if I ate this this gluten-free rice bread or corn bread, etc. So it really started to get me asking different questions. And so I started reading about the history of grain in and of itself. And TJ Osborne, who discovered prolamines, he's actually the who we call the father of plant biochemistry. He discovered prolamines and classified prolamines, which prolamines are a form of gluten. And so we have gluten being this family of proteins found within grains. Grains are the seeds of grass. Within the seeds of these grass, we have proteins that are storage proteins that are designed to feed the embryo of the grain so that it can grow and sprout and to form a new grass, right? So, but also designed to protect the embryo so that predators don't eat all the seeds and basically eradicate the species of grass. So these glutens are not only storage proteins, but they're defense mechanism proteins found within grains. And interesting that the guy who discovered this and classified it shares the same last name with me.
Small world, right?
Right. I was blown away by it. I mean, certainly I don't take credit for it, but I love that he did that work and has that available for us to read and to think and ponder on. But so we've got these gluten proteins, and there are over in 2010 there was a study done in Australia by Bob Anderson and his group. They discovered 400 new forms of gluten. And they found that 10% of these forms of gluten were worse than alpha gliadin in terms of celiac patient cells. So they found that 10% of these new discovered gluten proteins actually interacted and caused an inflammatory response in celiac cell lines greater than alpha gliadin. So we know there's more to this story, and I think it's important to say, Justin, that I wrote No Grain, No Pain to shed light on this information so that people could think clearly and people could get real scientific information and make good, smart decisions. And right now, if people go to the celiac sites and to the general GI doctors, what they're going to get is hey, if you have celiac disease, go wheat, barley, rye free. Don't worry about oats. Don't worry about corn. Don't worry about rice. And the vast majority of them are not going to heal. The vast majority of them are going to go on to develop multiple autoimmune diseases and have a lifespan that's 26 years shorter. So I felt like getting that information out there to the world was an extremely important part of my mission.
Love that. And I had a patient just maybe a month or two ago, came in with severe RA, had multiple surgeries on her spine and hands because of the actual disfigurement. And she had been on gluten-free diets, but then we kind of upped it one notch with a true gluten-free diet or an autoimmune diet following a lot of the same tenets in your book. And her pain, 30-year pain, literally vanished in less than a month. I couldn't believe it. So this stuff is real. So a lot of the things that you're talking about should be a first line defense with anyone with chronic pain or joint issues. And it's too bad the rheumatologists out there aren't holding this book up and giving it to all their patients.
Yeah, I would love to see it become a primer in rheumatology internships and rotations in hospitals across the country, and maybe one day we'll get that to happen. I actually, what's ironic is I started this whole thing started for me in rheumatology. I was fortunate enough to do a rotation in the VA hospital here in Houston, Texas, in the rheumatology department. And so what I got to see firsthand was patient after patient on methotrexate, on steroids, on immune suppressing drugs. None of them really ever got better. It was a horrible environment for these people. And then the surgeons would come in on one day a week, and they would do these surgical consults, and it was kind of like a mill. So, the patients would get drugged with immune suppressants. They really didn't get better. Their joints continued to deteriorate. And then they got surgical consults and got surgical joint replacements. And then they were back 10 years later with the need for a secondary joint replacement because their other one wore out. And so I got to see kind of all these kinds of patients going through that rotation through the VA hospital. It was very eye-opening and enlightening for me, and it's actually what led me down the path of even investigating diet as a potential cause for autoimmune disease.
Yeah, and a lot of people talk about gluten-free being kind of like a fad, and I think people need to kind of realize if you study the paleo diet, gluten-free from a true gluten-free perspective that you echo, really cutting out the grains in general, is not a fad. It's actually has history of 10,000+ years, it being in our, in part of our diet and lifestyle. But really, what is the fad is the gluten-free substitutes that are being added in. I mean, you don't ever have to put a label on broccoli being gluten-free, but you have to put a label on maybe rice flour or potato flour being gluten-free. So can you just talk briefly about the misnomer of gluten-free being a fad and then compare it to the true gluten-free aspects?
Yeah, so I mean, in any diet trend, and we've seen this with Atkins and South Beach, and we've seen this even with paleo and ketogenic diets, and probably the most famous of all is the gluten-free diet, right? Is what happens is big business, big companies take advantage of ignorance, and they take advantage of ignorance through marketing. So gluten-free is a perfect example of this. We've got, tons of companies that are out there. I think some of them really started with good intention, Justin. I think, not really understanding what gluten truly was. They were just trying to create options for people with celiac disease, rice breads, corn breads, and pastas, etc. But I mean, the reality is we have the science and we have the knowledge, and now that they're continuing to do that, to me, now there's an ethical and moral obligation for them to reevaluate their business models and to come back and say, hey, we need to look at this in a different way. But if you look at what they're doing, first of all, we're taking people who are very sick, autoimmune disease, right? Years, decades of damage. And we're saying, hey, cut out gluten, but eat crap. I mean, that's literally what these marketers are saying is cut out gluten, but here it's still okay. Coke is gluten-free. Snickers candy bars are gluten-free. And hey, by the way, this genetically modified corn that we just shaped into the form of pasta spirals so that you can still eat macaroni and cheese, we want you to go ahead and buy a ton of that for 10 times what you'd pay for regular macaroni and cheese. It's not healthy for you, but we're gonna label it gluten-free, and we're gonna kind of put the trend out there that gluten-free is healthier. And that's what marketers have done. That's what companies have done, is they've created this kind of trend in the market that says, hey, gluten-free is better for you. But the problem is that the vast majority of people out there are ignorant to the fact of what gluten actually is. So they're just going out and buying gluten-free products, right? They're eating them and they're still feeling like crap. And then they're saying, hey, why do I still feel like crap on this gluten-free diet? It's because they're not really on a gluten-free diet. Two, they're eating food that isn't good for them, right? And the cardinal rule of nutrition, you can't get healthy or stay healthy eating food that isn't healthy, regardless of gluten-free status. There are, sugar's gluten-free, but it isn't good for you. And so if your diet is 60% sugar, you're still going to feel bad. You're still not going to heal and recover from years of chronic autoimmune damage. So it's important to understand perspective. And perspective for the person who needs this diet is that, look, you've been sick and you've been accumulating damage, inflammatory damage in an overreactive immune system for decades. That requires a degree of stoicism in the diet. That requires a degree of discipline. It requires a degree of willpower and change and desire to change. If your desire to get healthy is greater than your pain, then you will make these right decisions. If your desire to get healthy is not your priority, then you'll continue to buy these processed foods and you'll continue to buy into this marketing hype. And you'll be one of those statistics where, or you'll be one of those people out there that say, yeah, I tried that gluten-free diet thing. It didn't work for me. And it's not that it doesn't work. It's that it didn't work for you because you didn't apply it correctly.
Exactly. That makes so much sense. And I have so many patients that we even go grain-free, but there's one element, because you talk about the pain in your book, All About Pain. I find some patients have to really cut out some of the nightshades, the tomatoes, the potatoes, the eggplants, peppers, and we know there's a high amount of alpha-solanine and glycoalkaloids that can be very irritating to the joints and cause pain. Can you touch more upon the nightshade piece in pain?
Yeah, so I mean, nightshades in and of themselves, especially for rheumatic arthritic conditions, we see this more. So like a person with a thyroid condition, we might not see nightshades be as much of a problem. But if somebody's really suffering with joint pain, these compounds in nightshades really have a great tendency, if there's an intestinal leakage or a leaky gut or a permeability, they have a tendency to travel to the joints and really create a lot of irritation and breakdown. So this is one food group that really needs to be looked at with aggression at removing. And I see it in very chronically, and a lot of patients have to remove it indefinitely, meaning that it's not like remove it for the next 6 months and then bring it back in. It's a remove it because for you, as a unique person, as a unique genetic biochemical individual, this group and this compound of foods, it irritates your joints. It's actually, we could actually look at nightshades with rheumatic pain and say they're probably just as much of a problem as grains are, and that we really want to get them out of the diet. Potatoes, peppers. One of the nightshades that people tend to forget about is a goji berry. I mean, you buy the goji berries in these, you go to Whole Foods or like Trader Joe's and buy the bags of berries frozen to make smoothies and stuff like that. And a lot of times goji berries are in these mixes. And you got to remember, goji berry is a nightshade. Now, one of the other nightshades that people tend to forget about because you don't eat it is tobacco, as you smoke it. And so let's say that you live, and I just had a patient, she's living in a home, her father smokes, she's getting exposure to secondhand smoke, she's got chronic rheumatic pain, and what ends up having to happen is we got to get this girl out of this place and into her own place, so that, and she was an adult, so we were able to make that recommendation. She was able to get out of there and basically was able to recover a little bit better. Now, you will see a higher tendency of people who are smokers developing rheumatic arthritic pain, and that's one of the reasons why, is that tobacco is a nightshade.
Well, I just learned 2 new things, goji berries and tobacco. That's great. Good clinical call on that one. And what's the mechanism of gluten actually driving the joint pain? We know we have the underlying leaky gut, which can cause all these proteins, undigested proteins, to kind of get into the bloodstream. We know the immune system and maybe the potential molecular mimicry that's happening, where the immune response is calling out an APB for this type of protein, and then other tissues kind of get in the way because they look similar. What else is happening just beyond that molecular mimicry mechanism?
So, okay, you've got leaky gut, which, like you just said, it allows all these things into the bloodstream that, can travel to the joint, can travel to the muscles, and that's where the inflammation process is occurring. The immune response is occurring there, and so we're getting secondary or collateral damage, right? Collateral damage to the tissue as a result of the immune system mounting a response. But one of the other things is just the direct inflammation. So gluten has been shown to cause a number of different pathways in the immune system. It's been shown to activate a number of different ones. We generally tend, when we're measuring clinically, when we're measuring to analyze to see whether a person's making antibodies, we measure antibodies to something called anti-endomysial antibodies. We'll measure anti-gliadin antibodies. We'll measure anti-tissue transglutaminase antibodies. But when we're doing these measurements, we're typically only measuring IgG, which is one type of antibody, or IgA. Now, we make also IgM, okay, which is an antibody that very rarely gets measured. So you've got also IgE, which is an acute allergic response. And then you've got T cell responses and immune complex responses that are also potential pathways where people are reacting to gluten. But then you have this whole other pathway that isn't measurable at this point in time. We don't have a commercial lab that measures this. And this is the innate immune response. So antibody responses are called humoral immunity. It's what we would call adaptive immunity, where people get exposure and they create antibodies to what they're getting exposure to protect themselves. So that, the example would be like a virus. You get exposed to a virus, your body responds by making these antibodies to protect you. But in the case of a virus, the virus comes, your body attacks it, and the virus goes away. It's not like gluten where gluten comes, your body creates antibodies against it, and gluten goes away. Because if you keep eating the gluten, you continue to make the antibodies, you continue to battle it, you continue to create inflammation and collateral damage. So that's humoral immunity. Then we have innate immunity. And innate immunity is the immune system you're born with. Humoral immunity is the immune system you adapt with. So your body gets smart and basically takes the feedback from the environment and makes decisions, whereas innate immunity is what you're born with. And so there are specialized immune cells that look at things and they just don't like them and they're going to attack them. And so there's not a way that we can clinically measure innate immune response specific to gluten or specific to grain. It doesn't exist. There's no technology out there at this point in time. Maybe it'll happen in the next 10 years, but as of right now, it doesn't exist. And so that's one of the other mechanisms of inflammation damage is an innate immune response. And so what we'll see people with high levels of interferon gamma or tumor necrosis factor alpha. These are other markers in the blood. You can measure that they're high. They're markers of inflammation. But again, you can't measure that they're high because of gluten. But you can measure them and you can see that they're high, and then you can take gluten out of the diet, and then you can measure them again and see that they come down. So does that make sense? So you have these generalized markers of inflammation that you can measure. You can get a baseline, and then you can do a follow-up, and you can say, okay, yeah, we changed your diet, and these markers have come down. But there's not a test that says your markers are high because of gluten, because those markers can be high for other reasons too, Justin. They can be high because you have a bacterial infection or a viral infection. They can be high over trauma, over an ankle sprain, or over liver damage. So there are other reasons why these inflammatory markers can be high. So it's up to the clinician to kind of piece that together when he's working with a patient.
I totally agree with that.
The other mechanism of damage that we see in rheumatic arthritis, so in autoimmune arthritis, is infection. So when that gut is leaky, we get bacteria that now get access. And so some of the bacteria that are notorious for contributing to arthritic pains, Klebsiella and Pseudomonas, are two different species of bacteria. Another one is Lyme. Lyme is a very, very common cause and mimicker of rheumatoid arthritic symptoms. So you've got multiple forms of bacteria. So the other thing that's important to rule out is infection. So you've got food that can cause leaky gut, then the bacteria leaks in, and it can get in, and it can get into the joints and start creating damage. So now you've got, food started the problem, but bacteria is finishing the problem. So if you just treat the bacteria, but you don't treat the leaky gut, then you still don't win the war. So all of these things have to be looked at because it's the old scenario, which came first, the chicken or the egg? It doesn't matter. We can't answer the question, but we have to address the chicken and the egg if we're going to get a patient better.
Also, I think mycoplasma pneumonia is a big infection too for some of the joint stuff. Do you see that too?
Yep, it's another one, absolutely.
And I also notice where there's smoke, there's fire, because we have this systemic inflammation thing happening, and pain may be the first indicator for people that have that genetic predisposition, but we also see autoimmune issues, maybe even type 1 diabetes or MS. So how many other, they call it PGAS or polyglandular autoimmune syndrome. And they say, I think 78% of people that have one autoimmune condition, maybe it's RA or some type of fibromyalgia pain, probably have another one. How much of the patients that you're seeing individually in your office are having more than just the pain? There's something else right next to it or beside it that's happening.
Well, pretty much all of them. It's very rare to see a singular autoimmune disease that just presents in solo fashion, if you look. Now, a lot of times the patient's symptoms, whatever predominating symptoms they have, those are the ones they bring to the doctor, and then the doctor gives them a singular diagnosis. But I find if you're thorough and ask enough questions, you find that these patients don't have singular autoimmune conditions, and these can actually be measured too. There are a number of autoimmune tests that can be run if a person doesn't have a severe immune compromisation. You can run tests that measure different autoimmune responses to different tissues, and you can actually find in many of these patients 4, 5, 6 different autoimmune reactions going on in multiple tissues that explains a lot of their other mysterious symptoms. It's just a lot of times doctors don't dive in any deeper than just kind of, if the patient's got joint pain, they go to the rheumatologist, they run rheumatoid factor, and anti-nuclear antibodies as tests. And if those come back positive, they give them a diagnosis of lupus or RA or reactive arthritis, and that's where it ends. And the patient, and then they start putting them on drugs, and then, maybe that patient's tired too. Maybe that patient has other symptoms like chronic brain fog and fatigue, but they never get that piece put together. They never get tested for brain antibodies or neurological antibodies. So they never even know that piece is part of their underlying autoimmune complex problem. It just ends with the rheumatologist.
Exactly. And then you kind of talked about the dangerous medications that they're putting a lot of the patients on. What really bothers me a ton is that the first line therapy that they're using actually perpetuates the problem even more, because you have the NSAIDs, which then are going to create more of a leaky gut. It's going to lower glutathione levels, make it harder to detoxify the inflammation to begin with. Typically, there's going to be gastrointestinal symptoms, so they're going to be put on a proton pump inhibitor, which will then decrease stomach acid, which will make it harder to ionize minerals like selenium, calcium, magnesium, iron. They'll get anemic, they'll have low B12, and that's going to create more fatigue, more leaky gut, more brain and mood issues because of the LPS that you mentioned, the lipopolysaccharide. So then now, a couple years in, they're on an antidepressant. They probably have low libido. They're on a proton pump inhibitor, and they're on all these dangerous pain medications, creating more and more issues, decreasing detox. So it's like conventional medicine is setting these people up for a world of hurt. Can you talk about the conventional approach that I outlined briefly, and then your approach to getting to the root?
Yeah, so I call this the prescription pain trap, because what ultimately happens with chronic pain is you get patients that are put on, they're put on initially some form of pain reduction medication, typically a nonsteroidal anti-inflammatory like an ibuprofen or a Celebrex or a Mobic, one of these classes of nonsteroidal anti-inflammatories that will erode the mucosal lining of the GI tract and induce a permeability within the gut itself, and also induce ulceration within the GI tract. So it starts to affect their nutrition. Now, once you start affecting nutrition and you start reducing their ability to absorb and digest, now it's even harder for them to heal. So you've kind of established this. This is why it's called the trap, because you start with the medication, and the medication does reduce the pain. It is effective at that, but it's effective at keeping the person trapped in a state of always needing the medication and never being able to truly fully heal because of the damage to the GI tract. You also induce vitamin and mineral deficiencies in this way, vitamin C and folate, and as you mentioned, glutathione. These are nutrients that get depleted. And that's just nonsteroidal anti-inflammatory drugs. But then we look at some of the other drugs that are used in these patients, the steroids. So the steroids themselves, which inhibit calcium and magnesium and vitamin D. Vitamin D deficiency all by itself can cause an autoimmune condition. So if we're being put on a drug that causes a deficiency of vitamin D long term, and we're being treated with an autoimmune condition, we're allowing vitamin D deficiency to never kind of recoup. And so one of vitamin D's functions is it regulates immune response. It regulates how strong immune cells respond to a threat. That's why vitamin D deficiency can cause a hyperreactive immune system. And so again, these steroid medications cause these nutrient deficiencies. They also cause bone loss and water retention and bloating and weight gain. So now you take this person who's got pain and you've just given them a drug that causes them to gain weight and increases their chance of diabetes. And now they've got joint pain already. So you've increased the physical pressure on their joints because now they weigh more. So now that joint that's eroded and damaged is having to carry more weight. And so that extra weight now causes more erosion. You see, it's kind of a bleak scenario, isn't it? And then now we look at other drugs that sometimes get brought in. And these drugs are basically severe immune suppressants like Humira or Enbrel. And these things shut down the immune system. So now you start these medications and you're on them 5-10 years. Now you're looking at a huge increased risk for cancer and other kinds of infection. Well, we said earlier that infections play a big role, and the byproducts of infections, lipopolysaccharides, play a big role in perpetual joint pain. So it's a futile effort. In modern rheumatology, it is a futile effort to go that route and expect to get resolution. All you will do is fall into that trap. Now, how do you get out of that trap? Because a lot of people say, well, I can't get off my methotrexate, or I can't get off my steroid because it hurts so much. Yes, you can, but it has to be done. It has to be done with scrutiny, and it has to be done with intelligence and purpose. The first step is you've got to change your diet. Diet change, first and foremost, has to be implemented because a lot of the inflammation is stemming from the poor diet in the first place. The second step is part of changing the diet is increasing your omega-3, omega-6 ratio. You want, for somebody with chronic pain, you want a 2-to-1 at least omega-3 to omega-6 ratio of fat in your diet. Now, that's really hard to achieve in modern diets today. Most people don't live on the coast where they have access to fresh cold water fish where they can get that quantity of omega-3. So we're going to use concentrated EPA and DHA, fish oils, so that we can drive that factor up. And I see working really, really well, anywhere from 4 to 8 grams. So a lot of people stop shy of about 2 grams and they never really achieve a therapeutic dose of omega-3 to switch that balance. So we're looking at 4 to 6 grams potentially there. Other things that can be done naturally is the use of turmeric. It's very, very effective at pain control. And it can be, you can use turmeric to cook with. So if a lot of Indian recipes, this is where turmeric hails. A lot of our knowledge from turmeric actually comes from that culture, but it's been being studied more and more and more. And we know it has extremely powerful and potent anti-inflammatory and pain reductive properties. So the use of turmeric, and I recommend 3 to 4 grams of turmeric, concentrated turmeric, meaning it should be at least 90% or more concentrated curcuminoid. So it needs to be standardized to contain that. Otherwise, you've got to use so much turmeric in your cooking, it's really, really hard to achieve that level for pain reduction. So if we're trying to get pharmacological pain reduction, we really got to go high doses. We can't go small doses.
And only 15% of that's absorbed too, I've seen.
Right. So you can use things like pepper, black pepper, bioperine, to enhance absorption. Then there are also lipophilic forms of curcuminoids, meaning they're fat-soluble forms that get absorbed better than your traditional powders. So those are all things that if you've got a good functional medicine doctor who can guide you, that ultimately is a really smart thing to have. Now, one other thing that works extremely well for kind of pain reduction in these people, well, there's a couple. I'll talk about a couple more. One is a proteolytic enzyme. Proteolytic enzymes work extremely well at modulating pain. And there are a number of good clinical brands that are out there. I actually have my own formulation called Matrozyme, but they work really, really well at pain reduction and inflammation control. You've got to get the dose high enough. And then the other thing that I find that is very, very helpful is something called an SPM. It's SPM stands for Specialized Pro-Resolving Mediators, and these are byproducts of fish oil. So what these are is ultra-concentrated resolvins that are derived from EPA and DHA that have a tendency to shut off the inflammatory cascade when it's overreactive. And so this is one of those things that can be used. It's clinical, so you can use it clinically in high doses for several months as you're trying to get a patient to wean off some of their pain medications and get them moving back in the right direction. So again, if we summarize, the diet's got to change. Inflammatory foods have to go away. Grains got to come out. Nightshades got to come out. I recommend that dairy comes out. I recommend high levels of omega-3 fatty foods, as well as high levels, 4 to 8 grams a day of omega-3 fatty acids, concentrated EPA and DHA. I recommend high levels of turmeric, anywhere from 3 to 4 grams a day, concentrated curcuminoids, at least 90%. I recommend proteolytic enzymes, and I recommend SPMs, specialized pro-resolving mediators, to help with all of these different things to wean that person out of that prescription pain trap.
And you also use Gluten Shield as well. I think you formulated that. It's very high in dipeptyl peptidase 4 to help with any cross-reactive gluten. And you also use a lot of anti-inflammatory herbal blends. I think you use like your GI Soothe or your GI Restore. Is that true too?
I do, yeah. We try to seal the gut. And so the difference is, Justin, as you know, when we're doing a podcast together, we're trying to give a general quantity of information to people. Ultimately, what I recommend, if somebody has an autoimmune arthritis or an autoimmune condition, really to work with a doctor like yourself or myself or another functional medicine expert who has these things at their disposal and discretion, but also has the ability to run highly specialized types of tests. Because the testing, we're giving general advice, and it's good advice, but highly specialized testing allows us to take the guesswork out. Because for some patients, look, for some patients, it's not a bacteria at all. It's a yeast overgrowth. And for some, it's not bacteria or yeast. For some patients, it's that they're I had one young child, terminal, allergic to blueberries, right? Wow. And every morning, blueberry smoothie was breakfast. So this is the kind of specialization. You can do all these right general things and still be struggling to find an answer. And that's why taking the guesswork out, sometimes is the best thing that you could possibly do.
That's great. So in summary, get the food dialed in. Go get a good functional medicine doctor in your corner to get the right supplements, whether it's getting rid of the infections, adding in digestive support, whether it's specific enzymes and hydrochloric acid, anti-inflammatory herbs to help reduce inflammation, anti-inflammatory fats, and then healing, repairing nutrients. Is that a good summary to start?
Yeah, it's great. Perfect summary.
Good. And then you touched upon the lab testing. You already talked about we have some of the immune testing, IgA, IgG, which is indirect. It's not looking at things directly. And we know based on whether you're weakened immune system, that may even come back false negative. You also talked about the conventional testing, looking at endomysial antibodies, transglutaminase, and then also your typical villus atrophy, where we need like an 80% reduction in those microvilli in the small intestine to even be able to pick up celiac, which is one out of hundreds of manifestations of gluten sensitivity. But your big thing is you've really gotten into the genetic testing, and you've laid out the conventional HLA, DQ2 and 8 as being the celiac, but then you go deeper into the different subtypes, A1, B1, and then all the different subtypes there. Can you just kind of give us an overview with the HLA, DQ genetic typing? And I know you do it on your site over at Gluten-free Society, and we'll put some links below the video. So if anyone's on the fence and doesn't know if they have a sensitivity to gluten, they can get the telltale sign, which is the genetic test. Can you go into that, Peter?
Yeah, so as you mentioned, a lot of these tests, they detect late stage disease. So you've got to have 80% of your villi destroyed before biopsy comes back.
Yep.
I actually had a patient, it was a 19-year trek for her. She literally had 19 biopsies. The 20th biopsy was positive. The first 19 were negative. And so I say it because a lot of people go to the GI doctor, they're dependent upon this test to give them a definitive answer. And it's not that you shouldn't get a biopsy per se. It's that, look, if you get a biopsy and it's negative and you suspect gluten, you shouldn't rule gluten out just because the biopsy is negative. You get false negatives with biopsies very frequently. One of the reasons why is the damage has to be severe enough to identify. Two, the intestinal tract is 22 foot long and has a surface area of a tennis court. So when you do a biopsy, you take one little tiny cross section, one little microscopic, it's like taking a little tiny pebble off the tennis court and saying, this pebble represents the entire tennis court, and it doesn't. And so you can't rely on that information as definitive. You can rely on it if it's positive. You can't rely on it if it's negative.
Right.
What genetic testing does, HLA-DQ, there are two genes. There's HLA-DQ alpha-1 and HLA-DQ beta-1. These are immune genes, and their job is, they're on chromosome 6, their job is to produce an antenna that sits on the surface of the white blood cell. And the job of this antenna is to identify what is good versus what is bad. So if the body says, hey, we don't like this, that antenna says bad guy, and then it captures it, presents it to the immune system, and creates some kind of inflammatory reaction. Okay, and there are a variety of different types of inflammatory reactions that can occur as a result of that. So there are certain patterns on the HLA-DQ alpha-1 and beta-1 gene that are gluten-sensitive patterns, meaning if a person has these patterns, their body, their genetic receptor is going to look at gluten as an enemy, not as a friend. And so it doesn't. What genetic testing tells us is that they're going to look at gluten as a friend or an enemy. It doesn't tell us whether they're currently reacting to gluten. It tells us whether or not they would react to gluten. And to me, that's far more valuable, because you can take somebody who's chronically sick and run a genetic test and not worry about a false negative, because a lot of these chronically sick people have immune suppression over time. Their IgA levels plummet, and they're malnourished, so they don't have enough protein to generate enough IgG to generate an IgG positive response. So if we're using these traditional labs, we have this high tendency toward false negative. Genetic testing doesn't ever change. You either have the gene pattern for gluten sensitivity or you don't. And so again, what it tells us, it doesn't tell us that you are reacting to gluten. It tells us that you will or you will not react to gluten. And these genes are activated by gluten exposure. So, a lot of people say, well, how do you turn these genes on? Well, you eat gluten and these genes get mad and they activate the immune system and create an inflammatory response. So it allows us to actually and accurately identify people who should be taking gluten out of their diet. And it's a genetic issue. So if we define gluten sensitivity, it's not a disease, it's a state of genetics. If you have the gluten-sensitive gene pattern and you eat gluten, your body's normal and natural response is going to be to create inflammation. The more gluten exposure you get over time, the more inflammation you make. The more inflammation you make, the more you perpetuate disease processes, and the more sick you become with time. So it allows us to say, look, you could be a little kid who doesn't have any symptoms but have gluten-sensitive genes. We can now say, look, get it out of your diet now so that in 20 years, you're not back in my clinic for me to treat your 3 or 4 different autoimmune diseases and 20 or 30 years worth of damage. We can actually isolate and identify the people who need to get it out of their diet right now, regardless of their illness. And that to me is a much more valuable clinical tool than any other form of blood test, because genetics don't change. Blood tests can vary dramatically.
And I know that the conventional celiac genes are 2 and 8, HLA-DQ2 and HLA-DQ8, which supposedly about 35 to 40% of the population has those. But when you look at the other HLA-DQ1, 2, and 3, and then 1 breaks down into 5 and 6 and the alpha 1, beta 1, and 3 breaks down to the 7, 8, and 9, according to, I think, Kenneth Fine, he says 90 to 95% of celiacs have at least one copy of those genes. So we know it went from 35 to 40 to 90 to 95, and then we originally thought, 1 in 133 people were celiac. So now we're starting to see the incidence is getting greater and greater and greater.
Well, and part of that has to do with, I honestly believe that most people are going to benefit from a gluten-free diet because most people have a degree of genetic gluten intolerance or gluten sensitivity. Nobody has done enough of broad-scale genetic study to confirm that one way or the other, but we've got data in our clinic that tends to go to that direction. But the other factor that you have to consider, it's a dose response issue. So the more gluten you eat, the more damage you create. So some people who don't eat as much maybe don't create as much damage and don't get quite as sick. But so you've got that as an issue. But then you also have certain medications that enhance the way we would react to gluten. And so these are and Dr. Fasano refers to these as the trick. He says what happens is there's a trick. There's basically an event that occurs, and then your body starts reacting to the gluten more aggressively to the point where you can identify it almost immediately. Those tricks per se are things like chronic nonsteroidal anti-inflammatory use, chronic Nexium or Prilosec or Zantac or antacid medication use, chronic antibiotic use, right? Chronic intake of chlorine because you're drinking chlorinated water, which disrupts gut bacteria.
Right.
These are the tricks per se that we have an environment, a modern environment that we have all these elements that damage our gut and make it more susceptible. So we already have genetic susceptibility, but now you add all these other factors and it accelerates the damage that's being done to the GI tract, so that we're getting more leaky gut, we're getting more of these chemicals and bacteria and other things that are leaking through. So we have a modern environment that accelerates the damage that gluten can cause. Because that's one of the big questions I get. Why, go back in time 50 years ago, why weren't people quite as reactive? Well, 50 years ago, you didn't have antibiotics in the major cities' drinking water on accident, right? 50 years ago, doctors weren't just hammering everybody with the antibiotic. You didn't have chronic ear infections in kids, and every other week the kid's getting put on a new antibiotic. You didn't have mothers delivering vaginal or cesarean babies where kids don't get normal bacterial flora from the vaginal canal when they're being born. They get nosocomial disease-causing bacteria as the first bacteria that colonize their GI tract. So we have all these other factors that are going on today that enhance gluten sensitivity and make it happen earlier in life. And I think that's the trend that we're seeing. But then you also add, Justin, you add to all that component, you add to the fact that grain is processed with heavy quantities of glyphosate. Right. Atrazine is another pesticide that's used. So these grains are soaked in pesticide. These grains are stored in large bins where they have this tendency to grow heavy quantities of mold, which produce mycotoxins.
Exactly.
Okay, and then you also have the fact that grain in and of itself, some of the grains have been hybridized so that genetically they're more complex and harder to digest. Some of them have been genetically manipulated, and so they actually produce their own chemical toxins. And so when we eat them, we're eating a lot of that. So you've got all these different factors that play a role in why we're seeing people respond so well to going grain-free. That's why the gluten-free diet trend is there. And if you look at historically at how this has all played out, it really started with Dr. Atkins. Yep. You know, he challenged the original conventional wisdom and said, look, quit eating carbohydrate. And what he was onto is I think he was on to two very important things. One, he was on to the burden of too much excessive sugar in the diet creates a problem, causes sticky blood and damaged blood, and it causes brain damage and brain fog, and it disrupts mitochondrial function and a number of other things. But I think the other piece that he really stumbled on, and maybe he was aware of it, maybe not. I never had a chance to talk to him, so I can't say one way or the other. But I couldn't detect that he was onto this by reading any of his books. Is that gluten in and of itself was in all these carbohydrates that people were eating as staple foods. And so just by eliminating those two factors, eliminating excessive carbohydrates, but also eliminating grain and glutens, people were dramatically improving their health. And so today we have evolutions of that. We've got the gluten-free diet, we've got ketogenic diets, we've got paleo diets, all kind of evolutionary diets that have moved and they all have the same thing in common. Right? And that's grain-free for the most part. Let's get the grain out of the diet. And I think that's why we see that, is all those different reasons that we just talked about. Again, that's why I wrote No Grain, No Pain. It's not another gluten-free diet book. So those of you who are out there listening, it's like you're tired of hearing about gluten. It's not another gluten-free diet book. If you really want to understand this topic and you really want to be able to apply it to your life intelligently so that you can restore your health, you got to understand that this book goes so much deeper than just a gluten-free diet.
That's great. So if anyone's on the fence about whether or not getting grains are a good thing for you, definitely get it out. But if you need more, the genetic testing is going to be great, especially the one that Peter's talking about, because it looks at that alpha 1, beta 1 subtype. And we'll put a link in the podcast and the video description below so people can access it. Now, in your testing, you also talk about HLA-DQ4 being the only genotype that technically isn't a gluten sensitivity genotype, but even if you have that, you may still have problems with gluten. Can you talk about that for a sec?
Well, it wouldn't necessarily be that you had problems with gluten per se, as much as it might be that you have problems with grain because of all the unhealthy other factors.
All the things you mentioned.
Right. Well, here's another thing. This has been around for a number of years, but it's really starting to come to head. There are several new classes of proteins found in grain that are non-glutens. And one of them is called ATI, amylase trypsin inhibitors. These are proteins that shut off your pancreas. So here we're saying we're shutting off your pancreas. Now we're shutting off the digestive function of your pancreas so that when you eat these grains, they're not being digested, because the grain's goal, it's a seed, right? It wants to come out. It doesn't want to be your food. It wants to come out of your butt with poop around it, because that's fertilizer so it can grow.
Right.
So it's developed mechanisms to protect itself from predators, and one is to prevent digestion. So these family of proteins called ATIs have been shown to shut down pancreatic function. But they've also been shown to activate something in the GI tract called a toll-like receptor. And one of the things that happens when you activate these toll-like receptors is you get an inflammatory pathway or an inflammatory cascade going. And so these ATIs not only create a gastrointestinal inflammation, but they also create a pancreatic shutdown. And these have nothing to do with gluten. So if we're talking just specifically, HLA-DQ testing is going to identify gluten sensitivity, whereas grain may be unhealthy for other reasons. And I want the audience to understand that. And ATI is one of those reasons. I wrote, there's 5 different, part in the book is I wrote, there's 5 different classes of new proteins that have been discovered in grains that are inherent to protect the grain. And so part of their job in protecting the grain is to defend it from us and our ability to digest it and our ability to process it. So you want to understand that those are part of the problem of grains beyond gluten. Pesticides are part of the problem. Molds and mycotoxins are part of the problem. None of these things have anything to do with gluten.
Right.
Heavy metals like cadmium and arsenic are part of this problem, because especially rice contains high quantities of these. And then you have what Atkins and so many others have discovered is that grains are super high sugar producers.
Right.
So we're going to get, the amylopectin, which is one of the elements to grain that causes elevations in blood sugar worse than sugar does. So you're going to get carbohydrate load that's going to induce a diabetic state. So you've got all these different reasons. We could say, look, regardless of your gluten status, maybe you are HLA-DQ4, but do you really want to eat this grain as a primary staple food in your diet? Because all of these other things are going to wreck your health too.
Totally agree. I got a study here from the Journal of Experimental Medicine. It says, moreover, ATIs, that's the trypsin inhibitors you just mentioned, may fuel inflammation and immune reactions and other intestinal and non-intestinal immune disorders. So this is right out there in the literature, everyone. So what we're talking about really is steeped in hardcore science. It's just most conventional doctors haven't really gotten to it yet.
And that's the sad part, Justin, is like, look, one of the biggest criticisms I take on, and I'm definitely a leader, a thought leader in this field. I know that to be the truth. And I don't say that, I'm not tooting my own horn, but I take on this criticism because I'm a chiropractor, and I've got other degrees and diplomas, but my heart is in chiropractic as well. And that because I'm not a medical doctor, so many people say, oh, he's a quack, he doesn't know what he's talking about. But the reality is, I didn't create any of this information like out of a whim or even out of clinical experience. This information comes directly from the medical literature. The problem is most doctors don't read their own literature.
Nope.
I happen to read an extra 15 to 20 hours a week in my spare time so that I can keep up with this type of information, because I feel like it's my job. If I'm going to help patients get better, I got to understand the latest and the greatest and the newest and even the oldest. And if more doctors took time to take that on and take their jobs more seriously, I think a lot of doctors just get into this regular routine of just cranking patients through a mill and not really seeing patients, not really hearing patients, just kind of going through the motions with patients. I think that's a travesty. That's one of the hugest problems we face in the United States, is that we've got doctors who have lost bedside manner, who've lost compassion, who are in it for the wrong reasons. And I'm not categorizing all doctors here. I know there's a lot of great doctors too. But look, I wouldn't have a clinic with a 5-month waiting list if those doctors that were out there, if most of the GI doctors that were out there, most of the specialists that were out there, if they actually took the moments and the time to read the literature and to apply the literature with their existing patients, I would be out of a job. But the fact of the matter is, I'm not out of a job. I'm busier than I've ever been in my life, because the experts who are supposed to be being the experts, who are supposed to be being the leaders and leading the field, are dropping the ball. So the chiropractor has to pick up the literature, and he's got to read it, and he's got to be able to apply it with his patients, and he's got to be able to apply functional medicine. And I just say that because that is one of the things that makes me the maddest. It's frustrating to deal with every patient coming through the door who's so frustrated because they've been to 8 or 9 or 10 different doctors who are supposed to be the leading experts. And so it's an uphill battle, Justin, as you know. Not only do we have to educate our patients, but we've got to overcome all the misinformation. And look, a lot of these doctors, had a patient come in to see me last week. Her child had hives, had hives for years. They didn't know why. So they were seeing a pediatrician. They were seeing an allergist. The kid had been taking allergy shots for 2 years. And the doctor said, well, it's going to take about 5 years of allergy shots to really get it to clear up. Now, that's ridiculous, to take 5 years of allergy shots to clear up hives. We cleared them up in less than 2 months. Now, when this woman took her son back to the allergist, she took all the paperwork and all lab testing that we did to this allergist. And she said, here, I just want you to know what we're doing because he's better. And, it's not like I didn't give you the opportunity to get him better. We've been doing this for 2 years, but I wanted to share this with you because I think that if you understand this, you might be able to help other patients. And this doctor rolled his eyes at her.
Unreal.
And basically laughed at her and said, well, if it's working, keep doing it, but it isn't really important. And it's like, shame on that doctor. I could tell you something right now. If a patient brought in information to me, if I had been treating a patient for 2 years and not been able to get them better, and and they came back and said, look, I visited another doctor and this is what we did, and it got me better, you could bet your bottom dollar I'm going to be on the phone with that doctor as soon as that appointment is over, trying to figure out where he's doing something that I'm not doing. How could I better improve my own skill set so that I can help more people? But the attitude with a lot of these doctors is, look, if it's not mainstream, it's quackery, which is BS. And if he's a chiropractor, he doesn't know very much and he's not qualified, which is also, as you know, BS. We have our background in education is so advanced compared to what people think that it is. And anyway, that's a horse we don't have time to get on, but I just had to say that because, a lot of people, that's I always say, look, if you doubt the information in this book just because I'm a chiropractor, shame on you. It's documented. There are 33 pages of medical references. I didn't create this science. I just interpreted, put it out there for the rest of the world in a manner that's consistently easy to read so that it can be applied. So get out there. If you're struggling with autoimmunity and you've gone through convention and it hasn't worked for you, get off your high horse and read the book and apply it and watch miracles happen.
That's great. That's great. And I think a lot of doctors, it's not like this great grand conspiracy, but I think a lot of people, a lot of doctors, for instance, they are under the impression, and most people are too, that if I didn't learn it in medical school, it's not important, and everything in medical school is going to be all I need to help my patients get better. And that's, I think, the grand assumption that most doctors and most people that go the conventional route are under. And I think you're really dispelling a lot of that in your book. And my last question here before we give you a send-off is, I heard someone on a podcast just recently talking about, well, go gluten-free, cut it out, and then add a little bit back in. And if you don't have a reaction or a symptom when you add a little bit back in, then you may be able to handle a little bit. So what's your perspective on just relying off of symptoms and adding a little bit of gluten back in? Is that the best way to do it, or should we look deeper?
Symptomatic response. It's like saying, don't exercise tomorrow. And if you don't feel diabetic symptoms tomorrow, then you know what I'm saying? It's a ridiculous statement. I don't know who said that, but shame on them. Shame on that person. Gluten sensitivity is a very, very serious issue. And if you're truly gluten sensitive, you shouldn't be introducing it back in. So I would say, there's no safe amount of gluten. There's, not if you're gluten sensitive. As a matter of fact, research shows that 20 parts per million, which is equivalent to a drop of water in a gallon of water, that amount of gluten exposure can create an inflammatory response for up to 2 months.
Wow.
So, absolutely don't reintroduce it and try and see if you can tolerate. Because what will happen is you go gluten-free for 6-8 months, you're going to feel dramatically better. Most people do. And when you feel better and your body is now healing, it's going to be more adaptive. It's going to be more resilient. It's going to have a greater reserve to combat, environmental problems. It's part of what we're after with wellness, is to have good adaptability to the environment without becoming sick. So to say, okay, take the gluten out and then start reintroducing it. It's like saying, okay, take the sugar out, and when the diabetes clears up and the blood sugar normalizes, start eating sugar in again. What'll happen is eventually you'll start developing diabetes again. So it's a ludicrous statement.
Totally agree. And I want to push everyone to head over to glutenfreesociety.org. This is where I got my foundational information about gluten. And even being a physician, there's tons of great info. And if you're a layperson just getting into it, there's still a ton of great info to kind of get your feet wet and even go beyond that with some of the clinical stuff. So I want to push everyone to go to glutenfreesociety.org. We'll have some links for the specific lab testing as well. Also, head over to drpeterosborne.com. Peter's got his awesome 7 highly effective habits for a gluten-free warrior. Lots of great information there. Anything else, Peter, that you wanted to kind of leave the listeners with? And then also, I'm going to go purchase my copy of your book here, No Grain, No Pain, right now. And I want to urge everyone to get their copy as well. Let's push it onto the New York Times list. I know you're almost right at the 10,000 mark there for sales, and we're going to push it way above it and get you on there so we can get more exposure to people that need access to this information.
I would just say, I'd leave with your audience, if you're suffering and you don't know why, and you've gone through convention and it hasn't worked for you, you don't have anything to lose. Try phase 1 and phase 2. It's a 30-day plan. Try it out. Take it for a test spin. You have nothing to lose. You have everything to gain. I would say to any of your listening audience, if you are healthcare practitioners or clinicians and you really want to get this dialed in and get this information, because part of my goal is to help people get better, and part of that is helping physicians. I've created a 10-hour postgraduate course for physicians. If you go to Gluten-free Society, there's a tab that says GF Doctors. Click on that and you can learn more about that. Take the course, because the information you'll learn from it and that knowledge that you'll get from it will allow you to help more people get better.
Love it. Awesome. Great information. And then last simple question, I ask it to everyone. I almost missed it with you. If you were stuck on a desert island, what supplement or herb would you bring with you? Or one supplement?
You know what? I think if I were stuck on a desert island, I would probably take my high quality multivitamin, simply because I want a diverse amount of vitamins and minerals in me. And if I'm going to be foodless or missing certain foods that are going to be devoid of certain nutrients, I want as much of a variety to prevent major malnourishment diseases like beriberi, pellagra, or scurvy.
Very common sense answer. I appreciate it, Peter. We're going to do a video basically summarizing all of the key points with all of the links on the video. Thank you so much, Peter. We really appreciate your time.
Hey, Justin, thanks for having me, and have a great afternoon.
You too. Bye.
Got a question for Dr. J? Go to BeyondWellnessRadio.com and click the questions button. Then tune in to hear the answer. Also, if you like the show, click below to review us on iTunes. For more Beyond Wellness Radio, go to BeyondWellnessRadio.com.